This lecture is going to cover what is normal as it relates to EKGs, specifically waves, segments, and intervals. Okay. The disclaimer here is that a rhythm strip, which is what you guys have been working on for the last several classes, is not designed to be used as a diagnostic tool. Rhythm strips are used for rhythm identification only. 12 leads are the ones that are going to be used as a diagnostic tool. So we're going to be getting into 12 leads, and this is kind of your intro to 12 leads. This presentation is not designed to be a complete diagnostic tool. It is designed for two things. One, to answer your questions, the ones you've been asking for weeks about why the P wave looks funny, or the T wave's upside down, or the QRS looks different. And then to give you a list of differentials to explore when you see a wave, segment, or interval that is abnormal. Okay, so it's going to be more a list of differentials for why the T wave looks funny, the P wave looks funny, or whatever, rather than a complete diagnostic tool, which you guys are going to cover when we lecture about 12 leads. Okay, so let's talk about what is normal for P waves. Okay, so we're going to start with P waves. You guys know from sinus rhythms that normal P waves are smooth, round, and upright. Okay, and they should all match, right? To add to what you already know, they should have a duration or time. When we measure time, we're talking this horizontal axis, a duration of less than 0.11 seconds, and then they should have an amplitude, which is measured from the isoelectric line to the top of the P wave, of less than 2.5 millimeters in height. Okay, so amplitude less than 2.5 millimeters tall. That would make the P wave normal. As you already know, P waves are representative of atrial depolarization. P waves can be abnormal, which you guys have seen. So some of the things that would make a P wave abnormal are the rhythm is not sinus. Okay, so think about a junctional rhythm. Okay, a junctional rhythm would have an inverted P wave. Okay, AFib would have no discernible P waves. Okay, for an example, so not a sinus rhythm. All right. Other things that can cause P waves to be abnormal are changes in the size of the atria. Okay, so left atrial enlargement, okay, will increase the duration of the P wave in lead 2. So we're down here at the bottom of the screen. Okay, left atrial enlargement will increase the duration of the P wave, meaning it will be greater than or equal to 120 milliseconds or 0.12 seconds wide. It will also cause the P wave to become more than one small box negative in V1. Okay. In right atrial enlargement, okay, over here at the top of the screen in this picture, the P wave amplitude will be taller. So it doesn't increase the width, it increases the height of the P wave. So right atrial enlargement, the P wave gets taller, 2.5 millimeters greater than that. Okay. And then in V1, it becomes more positive, greater than one box in height. Okay, so those are some things that would cause changes to the amplitude and width of the P wave. Next, we look at the PR interval. So the PR interval is going to be the time it takes for an impulse to enter the ventricles. So remember, the SA node fired, the impulse started in the atria, it depolarized the atria, it paused at the AV node, and then it got into the ventricles. So the PR interval is going to measure the atrial depolarization plus the pause at the AV node. Okay, it's measured from the beginning of the P wave, so from here, right, to the beginning of the QRS complex, and a normal duration is 0.12 to 0.20 seconds. Now, we call it a PR interval, but please know that sometimes you're going to have a Q wave, and sometimes you might not have an R wave. So it's measured from the beginning of the P wave to the beginning of the QRS complex, no matter what wave is first. Okay. Things that would cause the PR interval to be abnormal, there's no P wave. Okay, so if you don't have a P wave, you cannot have a PR interval. Okay. A PR interval might be abnormally short in a junctional rhythm, and this makes sense because if I draw our little bug down here, right, a junctional rhythm originates down here. Okay, so it would make sense that a rhythm that originated lower in the atria would not take as long to get through the AV node, okay? Other things that would cause this are an accessory pathway. So this picture that you're seeing is demonstrating an accessory pathway, okay? So this is a picture that demonstrates Wolff-Parkinson-White syndrome. And what happens in this is that, I'm going to draw kind of in the middle here, you have what would be normal depolarization, right? If this were normal, right? What happens in Wolff-Parkinson-White is that you have an accessory pathway. So normal depolarization, SA node, down, AV node, down, and that pause at the AV node exists right here, okay, in that PR segment. Okay? But in an accessory pathway, you have an abnormal connection between the atria and the ventricle that goes around the AV node. And so when that SA node fires, I'm going to do this in a different color, the SA node fires, it goes to the AV node and down the accessory pathway. Now, while the impulse is paused at the AV node, it is not paused here, and it is allowed to continue to go in. Well, because we only have one drawing, you know, we don't get two lines, right? What you end up with is a P wave that goes right into the QRS complex. Okay, so all of this stuff that's down here at the bottom disappears. Okay, not because the AV node doesn't exist, but because there's activity happening and you don't actually have an electrical pause. Okay, a PR interval that's longer than 0.20 seconds occurs when you have a heart block, which you guys have already, or an AV block, which you guys have already learned about. So in your like first degree heart block, for example, damage to the AV node is going to cause prolongation, okay, of the PR interval. Your PR segment can also be elevated or depressed. So, and we don't see these super often, especially elevated, but your PR segment might be elevated if you have atrial ischemia or infarction, which again doesn't happen as often. And then you could have PR depression with something like pericarditis, which you guys are going to learn about with 12 leads. The QRS complex is going to be measured from the end of the PR segment, okay, to the last wave representing ventricular depolarization. Okay, so it's measured from the beginning of the Q wave to the end of the S wave. One of the things you got to remember is that you don't always get all the waves. So you don't always get every wave. And this should be a reminder because we talked about this before, but you don't always get every wave. So if you only have an R wave, then it's measured from the beginning of the R wave to the end of the R wave. Okay, but no matter what, no matter how many of those waves you have, normal is going to be less than 0.12 seconds. And this is going to represent ventricular depolarization. Okay, so you may not have all the waves, just remember that. All right, some things that will be abnormal, okay, so, or that could cause an abnormally wide QRS complex, okay, so it's considered wide if it's greater than or equal to 0.12 seconds. You may have a conduction delay in the bundle branches, okay, so remember that ventricular depolarization is the flow of electricity through the ventricles, through the bundle branches, through the Purkinje fibers. So if those electrical high waves have any kind of break in them, right, or lack of electrical flow, right, then it's going to take longer for all of that tissue to depolarize and your QRS is going to widen out, okay? So conduction delay, this would be something like what we have represented in this picture, right? So over here you have your left bundle branch that is not, has a block in it, right? So now when the right bundle branch depolarizes, to get the left side of the heart to do its work, the electrical impulse has to go cell to cell to cell to cell to cell to cell around the left side, and that takes longer, okay? Other things that will cause it, ventricular rhythms, okay? So I'm going to erase this, but a ventricular rhythm, okay, is, let's say you have a ventricular rhythm, let's say your conduction system is complete, right? And you have a ventricular rhythm that originates right here where this blue star is, right? If it originates there, it doesn't get the benefit of the electrical highway coming down through the AV node and down both bundle branches. So what happens is that impulse still has to travel cell to cell to cell all the way around, okay? Same with a ventricular paced rhythm. Most ventricular pacemakers are placed, the wire is placed in one chamber, right? And so it's going to give that same appearance. Hyperkalemia can also cause widening of the QRS. Okay, so those are your differentials for a wide QRS. There's some other things that we'll talk about later in the 12-lead chapter, right? A Q wave. Okay, so we always, I always get lots of questions about Q waves. What's normal? What's abnormal? So Q wave, a normal Q wave. So what is a Q wave? It is the negative deflection before the R wave. Okay, so you don't always have Q waves. We don't always have Q waves. This is important. Okay, so a lot of people think that the Q wave is the first complex of the QRS complex, but if you don't have one, then the first complex would be either, would be an R wave, right? So you don't always have Q waves, number one. Number two, a normal Q wave is going to be less than one small box wide, okay, and less than a third of the R wave height, okay? So if I come over here to our drawing, here's our isoelectric line, right? I'm going to do my best to cut this in thirds without measuring it, but we're going to say that's 1, that's 2, that's 3, so we have it in thirds. This Q wave that we see is not, is less than 1/3 of the R wave. Okay, so I did thirds for the R wave, the height, right? And that Q wave is only 1 millimeter. A third of this is like 4 millimeters. So we are less than 1/3 of the R wave height. It does represent conduction through the intraventricular septum. So just know that, all right? And this would be normal. And it's also normal in certain views to just not be able to see them, okay? All right, things that make it abnormal. It's considered, if it's abnormal, it's called a pathological Q wave. And it's going to be considered abnormal if it's too wide. So we said it's that 1 box or more wide, or it's too deep. So it's greater than a third of the R wave height. Okay, so for example, we're going to start with this picture up here at the top. If I come here, this is my Q, right? This is my R. So if I take my R wave and I divide it in thirds, right? That Q wave is more than 1/3 of the R wave. Okay, so it's too deep. It is also more than 1 small box wide, so it meets both of these criteria. Okay, so a Q wave is pathological if it's too wide or too deep. This one is both. Okay, so it doesn't have to always be both, but this one it is actually both. It is too wide and too deep. Okay, so a pathological Q wave is indicative of a infarcted tissue. So a patient has had a heart attack, okay, and that tissue is dead, okay? So that is when you see pathological Q waves. When we talk about STEMIs, we'll talk about this a little bit more. Q waves, pathological Q waves can show up with an active MI, active heart attack, but they persist after the heart attack as well. All right. The R wave and the S wave of the QRS complex. Okay, so the R wave is any positive deflection of the QRS complex, and the S wave is any negative deflection after the R wave. They are going to represent depolarization of the left and right ventricle. So remember, the Q wave was the intraventricular septum, and then the R and S waves are going to represent depolarization of the left and right ventricles. Depending on where your camera is, the R wave could represent the right or the left ventricle, which we'll talk about with 12 leads next week. All right, things that are abnormal, okay? A secondary R wave. So we said any positive deflection of a QRS complex is an R wave. So you'll see in this picture right here where I've got this box that you have a positive deflection of the QRS complex, which makes it an R, a negative deflection following it, which is an S, and then you have another positive deflection, which is an R, okay? So this would be an RSR complex, okay? This is seen with a right bundle branch block, and we'll again get into that even more when we talk about 12 leads. But when you see that, you should be considering that the patient may have a right bundle branch block. Okay. Now, if you see RS, 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 that's VTAC. Okay. That's not a RSR, that's VTAC. All right, next thing we're going to talk about is the J point. And to do that, we have to talk a little bit about the ST segment. Okay. So we have another slide for ST segment, but we got to talk about what the ST segment is. So this picture, right, that we have shows the ST segment from here to here. Okay. So the ST segment is the area between the end of ventricular depolarization and the repolarization of the ventricles in what is the T wave, right? But in most cases, in a lot of cases, the ST segment is not perfectly flat, okay? So in a lot of cases, you get something that looks more like this, right? And you would say that looks like the end of the QRS, and that looks like this is the T wave, and this is probably the ST segment, but it's not flat. So when we talk about the J point, we're talking about the first part where the QRS ends and the T wave tends to begin, right? Or the ST segment tends to begin. This is important because this is where we measure ST elevation from, okay? So when you guys have heard the term STEMI, ST elevated myocardial infarction, really what that is a GEMI, a J point elevated myocardial infarction, because when we're measuring, that is the place at which we are measuring from. In normal pathology, it should be isoelectric. So you can see here, our J point is circled. It is isoelectric, right? So our isoelectric line is here. There is an exception in V2 and V3 where a little bit of elevation is allowed. Okay. Things that are abnormal, okay? So a J point that is elevated or depressed, okay? This can occur with myocardial ischemia and myocardial injury. Remember that ischemia is lack or not enough oxygen that leads to injury. Injury that is not corrected will lead to infarction, okay? So again, this is the point where we measure ST segment elevation or depression. It's that first point that you see right here where we make this turn, okay? Out of the QRS complex, where the QRS complex ends. Okay. All right, so ST segment begins at the J point, ends at the T wave, and again, like I told you, it's rarely a perfectly flat isoelectric line, which is why we have to talk about the ST segment, okay? Why we have to talk about the J point. Causes of abnormal ST segments. This is going to be important because everybody, when they're new, goes, oh, there's ST segment elevation. They must be having a heart attack, right? So they're having a STEMI, an ST elevated MI. Recognize that that is not the only cause of ST elevation. You have these things called STEMI imposters or STEMI mimics, things like early repolarization, a left bundle branch block, left ventricular hypertrophy, pericarditis, ventricular paced rhythms, and hyperkalemia. They can all cause ST elevation that's not related to an acute heart attack happening. Okay, ST depression is going to be representative of myocardial ischemia. It can also represent a reciprocal change to elevation. So if I see elevation in the front of the heart, I would expect that I would see depression in the back of the heart, okay? Or the top versus the bottom. So reciprocal meaning opposite. All right, T waves. All right, so T waves give a lot of people a lot of grief, but let's talk about what normal is, and then we'll talk about what's abnormal. So normal T waves are asymmetric with a steeper downslope. So what do we mean by that? I'm going to come over here to this T wave. The point of the T wave is about here, right? So if I draw a line through it, I can't draw a straight line, and I fold that in half, you can see that this part is not symmetrical with this part. So it's got a steeper downslope. That is a normal finding in a T wave. It is also less than half the height of the QRS complex. And you can see QRS complex height, this is about halfway. Our T wave is less than half, okay? It also should go in the same direction as the QRS complex. So you can see that our QRS complex is predominantly upright, and our T wave is also upright. This is normal, okay? There are some places where inverted T waves are normal, okay? So in lead V1, it is a normal finding to have an inverted T wave. The QRS in V1 is also negative. Okay, so negative in V1 and T wave negative in V1. Same thing in AVR. So in AVR, your QRS complex should be upside down and your T wave should be upside down with it. Okay. Isolated T wave inversion in lead 3 is considered a normal variant. Okay, so just know that. And then in leads V1 through V3 in children, it's called a juvenile T wave pattern. It can be normal for them to have inverted T waves. Okay. And then we said you guys know this already, but your T waves represent ventricular repolarization. All right, some causes of T wave abnormalities. There's a few slides on this just so you guys are aware, but T waves can be peaked, right? And that occurs in hyperkalemia, right? And in, they call them hyperacute T waves, which can show up right before ST elevation or persist with ST elevation, okay? So in hyperkalemia, you get tall, narrow, symmetrically peaked T waves. So you guys can all agree, I mean, in both of these images, these T waves are bigger than the QRS. But if I come over here and I draw a line as best as I can down the middle of this T wave, these are pretty equal, right? They're symmetrical. You have about the same amount on each side, right? So this would be indicative of something like hyperkalemia or high potassium, right? The other, your hyperacute T waves, large, broad, asymmetrically peaked, may show up before ST elevation and then again remain present with ST elevation. So they're both tall, they're both peaked, but if I come over here and I draw a line down the middle of this T wave, this is not symmetrical, right? You guys can see that. So this would be more like a hyperacute T wave that could be found before or with ST elevation. We see a lot of abnormal T waves, or a lot of abnormally inverted T waves as well. So in acute MI, so patients having an active heart attack, can cause inversion in contiguous leads. And it may stay that way after the infarction. So the patient has an acute heart attack, right? They have inverted T waves. They may have inverted T waves with it. Q waves, ST elevation is going to be the big one. And then after they've had stent placement or the MI resolves, the T waves that are inverted may stay that way, just so you're aware, okay? You can also see inverted T waves in a few different places. So when a patient has a left bundle branch block, this picture should look familiar from a previous slide, okay? This is a left bundle branch block. We expect to see T waves that are inverted in the left leads. Remember, think about while you're watching this where V5 and V6 are. They're on your left, this left side of your chest, right? One in AVL, look at the heart from the left shoulder. So they are left-sided leads. Okay, so left bundle, left leads, okay? Conversely, a right bundle branch block causes inversion in the right precordial leads. Think about how many you've got, or chest leads, right? You have V1 through V6, they all go on your chest. Okay, imagine you're putting them on yourselves. Which three are on the right, the furthest to the right? V1 through V3. Okay, so right-sided inversions, V1 through V3 are normal. Okay. In that finding, okay? All right, other places. So again, I want you to see the correlation here. Left ventricular hypertrophy, the left side of the heart gets really big, okay? And where do we see inverted T waves? We see them in the left lateral leads. Okay, so 1, AVL, V5, V6, okay? In right ventricular hypertrophy, okay, we see them in the right precordial leads, V1 through V3, okay? So you may also see them inverted in the inferior leads, 2, 3, and AVF with that, okay? And then a pulmonary embolism also affects the right side of the heart, causes strain to the right side of the heart, and wouldn't you know, the right precordial leads have T-wave inversion, the inferior leads have T-wave inversion, and they may also have this S1Q3 T3 pattern present, which we will talk about in class. So things I want you to gain from this: left pathologies. Usually the T waves are going to be inverted in the left leads. 1, AVL, V5, V6, right? Right pathologies, we expect to see this in V1, V3, or V2 and V3, or the right chest leads and sometimes also the inferior leads. Another cause of inverted T waves is increased ICP. So I'm going to get on my soapbox here for a minute. You've been dispatched out to a patient who was struck in the head. Upon arrival, they have decorticate posturing, they have a blown pupil, and they have irregular respirations. You already know that they have increased ICP just on that. When you do the 12 lead should not be the sign that, oh, maybe they have ICP. ICP question mark? You should have figured that out from your patient assessment already. It's cool to see, but your patient is going to tell the story, so just keep that in mind. Increased ICP can cause widespread deep T-wave inversions, which you guys can see here in V2, V3, V4, V5, V6, also in lead 2 over here, AVF, and lead 3, so in a lot of the leads. All right. Causes of abnormal T waves, so based on the shape. Okay, so biphasic means that the T wave goes in 2 directions, bi meaning 2. Okay, so if you have a T wave that is positive first, so QRS complex, T wave goes up and then down, okay, that is indicative of Wellens sign. Okay, so Wellens is a condition that occurs with spontaneous reperfusion of cardiac tissue. So usually with Wellens, a patient comes in or a patient calls 911, oh my gosh, I'm having chest pain, I think I'm having a heart attack. You arrive on scene, they no longer have pain, right? And you put them on the monitor and you see this pattern in your like V1, V2, V3, V2, V3 usually, and you go, that patient might actually be having a heart attack. They need to go to the hospital. Think of it as like a TIA for the heart, right? So Wellens is kind of like that. You got spontaneous reperfusion, kind of like a TIA, okay? And then in hypokalemia, which you see down here, right, the T waves go down and then up. And what I want you to know about this is actually what you have, and we call this a biphasic T wave. This is part of the nomenclature thing that we have with 12 leads that makes everybody's life hard, is that this is actually an inverted T wave and a upright U wave, but we frequently will hear this called a biphasic T wave, and that is indicative of hypokalemia. So nomenclature, whether you hear it as a biphasic T where it's negative and then positive, or an inverted T and a positive U, those are both indicative of hypokalemia. Sometimes hypokalemia can also present with like flattening of the T wave as well, something like that. Okay. All right, and then U waves. You've seen a few of these while we've done rhythm practice, and I told you guys not to worry about it, and I know you were ready to pull your hair out, and that's okay, but we're gonna talk about them now so you know what they are. But U waves are not usually present, okay? Doesn't necessarily mean it's bad when they are, but when they are present, what is considered normal is that they are less than 25% of the height of the T wave. So if I came over here and I broke this T wave into 4 parts, right? The U wave should be less than 25% of the T wave height, or a maximum of 1 to 2 millimeters. You can see that this one is like maybe 0.5 millimeters, right? Okay. And it should be in the same direction as the T wave. So if the T wave is up, the U wave should be up, okay? We think that T waves probably represent late repolarization of the Purkinje fibers. At the last time I looked, we weren't 100% sure, but that's generally what we theorize, is that it's late repolarization of the Purkinjes. Things that would make U waves abnormal. Okay, so prominent U waves are most commonly seen when the heart rate is low, so bradycardia, and in severe hypokalemia. Okay, so those are the most common times that you are going to see them. And here's some examples, right? Here's a U wave here, and then over here you can see it after the T wave as well. Okay, in most cases the heart rate is under about 60. Not always, but in most cases the heart rate is under about 60 for them to be present. Okay, they can also be present with hypocalcemia, hypomagnesemia, hypothermia, increased ICP, and left ventricular hypertrophy. So those are the other times we might see them. All right, the QT interval is going to be really, really important for you guys to understand. So The QT interval represents all of the electrical activity that happens in the ventricles in one cycle. So it's measured from the beginning of the QRS to the end of the T wave. So it is the depolarization and the repolarization of the ventricles. Okay, so there's two things that you have to know. One is that you have an actual QT. So if I came over and counted this, I'd go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We'll round to 11 small boxes times 0.04 seconds, right? And this would give us our actual QT, all right? Our actual QT, okay? But the problem is that as the heart rate changes, so does the QT. Okay, so remember that if your heart rate goes up, everything that happens in the entire cycle has to happen faster, right? If I wanted to fit more QRS complexes in this strip, everything would have to take up less time. Okay, so when the heart rate goes up, the QT goes down. When the heart rate goes down, the QT goes up. And the problem with this is patients present with all kinds of different heart rates. So what we do is we say, how can we make it standard? So what your monitor does is it calculates this and it says, what if the heart rate was 60? What would the QT be then? So there's an algorithm, a mathematical equation, you can look it up if you want, but basically the corrected QT corrects the QT as if the heart rate were 60, so that we can compare them evenly from patient to patient. Okay, so the QTC duration, corrected QT duration, for men is about 350 to 450 milliseconds, or 0.350 to 0.450 seconds. In women, 0.360 to 0.460 seconds. Okay, you will see some varying ranges with this. Some go up to like 46 and 47 for men and women, just so you're aware. But what you really need to be concerned about is if this is greater than 500, we are at a huge risk for anybody for torsades. Okay. Some things that would cause the QT to be abnormal. Okay, so a short QT is usually congenital, and we're talking again about that corrected QT is usually congenital. Prolonged could be medications. There's a ton of medications. Zofran is one that we're very familiar with that causes a prolonged QT, but there's a ton, if you look them up, a ton of different medications that can do it. It can also be congenital. Anything that changes the width of the QRS, because remember what happens during the QT, right? The QRS happens, right? The ST segment happens, and the T wave happens, right? So if something prolongs the QRS, like a bundle branch block, then the whole QT would probably be a little longer. If the ST segment gets long, like with some of our with like hypocalcemia, right? Then that is going to spread that out, and then your QT will be long, right? And then again, like I told you, you're at risk, a greater risk for torsades if your QT is over 0.50 seconds or 500 milliseconds. All right, the TP segment. Okay, this is where when we say isoelectric line, this is what we're talking about. So the TP segment, this one's called TP interval because it has a U wave in it, but it's this part right here. Okay, it's the flat line. Okay, it's measured from the end of the T wave to the beginning of the P wave, and it represents the time between electrical activity. So your heart, your whole thing, unless you have a U wave present, is at rest. Okay, so it's important because it's obviously your heart has to rest, and then also because it is our reference point for ST elevation, depression, PR elevation, and depression. Okay. Some things that would make it abnormal. Okay, I just thought this was cool. I don't think you're going to see it in any lecture anywhere, but a downsloping TP segment, right? As you guys can see here, it's like this, right? Okay, this is called Spodek sign, and it is found in almost a third of patients that have pericarditis, and in 5% of patients having an MI. So that is where you would see that the most. I hope you enjoyed this lecture. That's the end of what I have to talk to you guys about, and I'm ready to teach you guys 12 leads, so enjoy this, and we'll do 12 leads next week.